Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along, and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Cheema. Dr. Cheema serves as a clinical assistant professor of medicine and teaches residents and any medical school students. She's an internal medicine board certified physician who completed her residency at the University of South Florida. She's a mentor to many students and a published author in several scientific journals as well. Dr. Cheema participates in community service and believes in health for all, while also running a clinic for low-resource patients. And now it is my honor to request Dr. Cheema to begin today's session. Thank you.
Thank you, Akash. Very good morning, everyone. It's a great honor to be with you this Saturday morning again with you guys. And again, someone attended my prior sessions, I always start with a question, why? It's a Saturday morning. We can be with our loved ones. We can be going out for hiking, some fun in nature parks, or spend time with family and friends. So this Saturday morning, why we are here? Can someone talk about it? Can someone tell me, can write on the chat box? So we all know why we are here today, this Saturday morning. Let's see if we get a few responses, then we'll move on. We have a few participants here. Let's see. I'm here to explore internal medicine. Okay, good, very good. So I know I can tell you one thing, there's no wrong and right answer. Just write down whatever you think, why you're here. You want to learn more about a field. What's your passion about? Because this Saturday morning is a weekend, right? You should be out for having fun, but we are sitting here in front of the computer, learning something. Right, so we got some responses, build knowledge on different specialties, very good. And Akash mentioned to learn more about telemedicine specialty, okay, good, very good, yes. So that's the reason we are here. So it shows our passion. It shows our passion that we want to learn, we want to be here to learn, to achieve our goals, right? We all have goals in our life. So we take small baby steps to achieve our goals. And for that, we need to be passionate. I always tell everyone, your passion and profession should be the same. So do whatever you love. So if you really love the medicine, please go for it. It's really good profession. It's very rewarding. Of course, very hard work, very stressful. But at the end, I would say, if someone asked me, you want to change your profession? I would say, no, I will go back again in medicine. All right, let's go over. I want to start, as Akash mentioned, briefly about myself. I'm internal medicine. I'm as an internist. I've been doing hospital medicine as well, long-term care, and I did my residency from University of South Florida. So next, please. So as we talk about, do we have next here, please? It's not showing at my end. I think, let me see. Okay, here we go. All right. So what do you think when you hear the word internal medicine? Let's make a word cloud. And most importantly, I forgot to mention, I would like your participation. I don't want to let anyone to sleep here, okay? Since you're here, so we have to work together as a team. You will teach me, I'll teach you, okay? So we'll work together. So can you please write down what do you think when you hear the word internal medicine?
So we'll be sending out a Paul EV link in the chat box, and you'll be able to write down, and the word cloud will be updating live.
Again, I told you there is no wrong and right answer. Please participate, and we are here to learn. I will learn from you guys, and you will learn from me, right? So just type in, and we want to make a word cloud and see how it looks like. I will give you some time, no rush, take your time. We are getting a few responses. Let's see. Treatment, internist, pathology. Okay. function, treatment, internal care. Okay, good, very good. Awesome. Yes. So I know you guys are here to learn. So I'm going to talk about internal medicine is a field that dealing with the care of the patient. Our main goal, medicine is a care for other people, right? With passion, with compassion. So basically it's a dealing with the care of the patient, diagnosis, treatment, and prevention of the diseases. And of course, as mentioned, it's very important to have the compassionate care for adults. And the physicians who are specializing in internal medicine are called internists. Sometimes if they work in the hospital, they call it hospitalists as well. So these are different interchangeable terminologies we use. And the most fascinating part of internal medicine to me that I really enjoy is to care for the patient, how we can do that. When patient comes to you for any problem, we will have a similarity case as well. So we diagnose the patient. And then patient tells a story, patient tells the history. We'll go over those points as well, how we obtain the history. So we diagnose and then we help them. How do we help them? We manage the patient. We help them with their symptoms. And it involves all the organ system. So, and it says a broad spectrum of the health issues. And I will go over one by one very briefly, and then we'll start a similarity case as well, especially when we are trained to manage seriously sick patients as well. Like when I had my rotation, when I was doing my residency training, so we do have rotations in the ICU, we have rotation on the medical floors, we have cardiac care unit rotations as well. Then we have electives, there we can do outpatient rotations. So it's a whole organ system we learn how to manage the patients. So I will go over briefly. So basically, in a short, very briefly, internists perform physicals, they manage illnesses through, of course, by the diagnosis, then treat them with the medications if needed, and as well through non-invasive procedures, non-invasive methods. How? Like lifestyle medicine, lifestyle modification, counsel the patient, educate the patient, and most importantly, diet and exercise. All right, so I will go over pretty quick. When we had internal medicine rotations, we have medical floors, we have urgent care rotations, we have ICU. ICU means intensive care unit. We have CCU means cardiac care unit. We have emergency room rotations as well. We have better idea when patient comes in, how we manage in the emergency room as well. And then we have electives where we do the outpatient in the clinic setting as well. And electives, we can do whatever we would like we can do cardiology, nephrology, we can do rheumatology. So these are different options we have. So next I will move on. So what is the inpatient care? What is the outpatient care? So inpatient care is basically in the hospital setting, in the acute care in which patient needs more extensive care that we cannot manage in the office setting. And outpatient care, like is all you all have the physician and you go your routine physical exams, is called office setting. So we call it inpatient care and outpatient care. So next we have acute condition. Acute condition, as I mentioned, is sudden onset. It's an intense medical condition that we cannot manage in the office setting or at home or nursing homes or assisted living facilities. So we recommend the patient to go to the hospital setting to have a more better acute care. And then chronic conditions are the long-term recurring conditions like diabetes mellitus. We manage in the office setting, right? Then hypertension. So these are all the conditions and all the chronic conditions we manage in the office setting and also as a chronic condition as well. So next I will talk about what is as we discussed, inpatient care, outpatient care. So which conditions, which medical problems we manage as inpatient and outpatient. So basically they are interlinked. Sometimes the conditions we are managing in office setting, and all of a sudden they have an acute flare up, then patient need inpatient care and we send the patient to a hospital or urgent care to be addressed. So inpatient care, first of all, I will go over all the different subdivisions of internal medicine, like we manage what we do as a hospitalist, as an internist in the hospital setting, neurology cases. So what do we see? We see the stroke patients called CVA, cerebrovascular accident. Then we have a transient ischemic attacks. Then patient comes in, some symptoms of the neurologic deficit. We evaluate the patient in the ER, then ER doctors call us. Patient need to be admitted to do further workup, why patient has those symptoms, to manage them, to stabilize them before sending the patient to home. Then outpatient care settings, neurology conditions that we can manage like headaches, migraines, dementia patients, major depressive disorders, ADHD, bipolar disorders. These are all interlinked with the psych as well. So we as internal medicine, we can manage as a chronic medical condition. And of course, whenever we need help, we can refer to the specialist as well. Next, I'm going to go over cardiology cases. So inpatient, again, coronary artery disease, also called myocardial infarction. CHF, congestive heart failure. AFib is called atrial fibrillation, means irregular heartbeat. It's called arrhythmias as well. There are different kinds. I will not go in detail. I'm just giving you overview, the inpatient care and outpatient care, so you have a better idea what does it mean. And then hypertensive emergency cases that need to be admitted to the hospital, syncope workup, pre-syncope is all the inpatient. For outpatient, what we can do? We can manage, as I mentioned before, hypertension we can manage hyperlipidemia, we can do coronary artery disease. Of course, when patient was admitted for the acute coronary syndrome, so we stabilize the patient in the hospital setting, and then we discharge the patient. So who will follow up, right? Either cardiology or the internal medicine. So there's a family doctor, right? So then the internist or internal medicine physician manage those cases on the outpatient setting as well. Congestive heart failure, atrial fibrillation. So these are all the cases. Next, so we have a pulmonology. So inpatient care, we manage both, I can say inpatient, outpatient, COPD managed as outpatient, but when there's a flare-up, patient need to be admitted to the hospital for acute management, then asthma, exacerbation, pneumonia. So pneumonia is, again, we can manage an outpatient as well, but again, if patient is elderly patient and they have abnormal labs, they are unable to take oral medications, they are nausea, vomiting, so patient need IV medications. For that, patient need to be admitted to the hospital. So these are all the cases for inpatient and outpatient care. And then next we have gastroenterology cases. So gastroenterology is my passion. I really like gastroenterology. So inpatient care, whenever patient comes with an upper GI bleed, GI means gastrointestinal bleed. It can be upper GI bleed, it can be lower GI bleed. Then we have a pancreatitis cases, can be admitted to the hospital for acute management. Then cholecystitis, then colitis. And outpatient care, we can do GERD, that's a gastroesophageal reflux disease, dyspepsia, irritable bowel syndrome. So these are all the cases we can manage as an outpatient. Next, we have nephrology. So inpatient, outpatient care, again, acute renal failure, we can manage outpatient, inpatient, but again, it depends how bad it is. How basically we look up the kidney function, the creatinine, we look up the GFR, that is glomerular filtration rate. You might read undergrad students for pre-med, they might heard of GFR. And then hyponatremia. Hyponatremia means low sodium level. Hyperkalemia. Hyperkalemia means elevated potassium levels. These are all the chemistry. When you read in the biochemistry, so you say, why are we learning sodium? Why are we learning potassium? So it's all biochemistry. Because at the end, when you will be, as a physician practice, you have to manage all these cases. Hyponatremia, low sodium level. Hyperkalemia, elevated potassium level. Then diabetic nephropathy. These are all the cases we can manage. Then nephrolithiasis means stone in the kidneys. All right, next we have endocrinology cases we manage. So endocrinology is diabetes mellitus, hypothyroidism. So these are we can do as an outpatient. And when the patient has a hyperglycemia, that's called poorly controlled diabetes, when the patient is hyperglycemic, and when patient goes into diabetic ketoacidosis, means acid level build up in the body. So patient need to be admitted to the hospital to manage before patient discharge and then we can manage as an outpatient. So as an outpatient care, again, as I mentioned, diabetes, hypothyroidism, vitamin D deficiency manage, obesity, overweight, osteoporosis, polycystic ovarian syndrome. All right, next we have infectious diseases. So again, as I mentioned before, lung infection, urinary tract infections, skin infections, any eye infections like conjunctivitis, stye, ear infections, otitis media, otitis externa. And then when patient has severe infection, it's called sepsis or SIRS that we cannot manage outpatient, patient need to be admitted to the hospital for all these infections to be managed with IV medications. And then osteomyelitis, of course, we admit for the IV medication, and then we can do as an outpatient by the transferring to the long-term care or assisted living facility. All right, next we have, again, the dermatology cases we can manage as well. Of course, the dermatitis we can manage, atopic dermatitis, acne vulgaris, fungal infections, skin soft tissue infections, some bites and infestations we can manage as an internist. Next, we have hematology. So hematology is all the blood-related medical conditions. Inpatient, outpatient care settings, we can manage anemia, means low hemoglobin level. Thrombocytopenia means low platelet count. Platelet count is the one that we need for our blood clotting mechanism. Then leukemia. So these are all the blood disorders that we can manage in inpatient and outpatient care settings. And again, the rheumatology and musculoskeletal cases, like our patient has a patient comes with a fall, or MVA means motor vehicle accident. So have some, God forbid, have any fractures, so they need to be admitted. So basically, orthopedic are the one who need to do the procedures on them, but they are admitted on the medical floors. And as an internist, as a hospitalist, we do manage as a primary care physician in the hospital. And then we consult the orthopedic physicians, and we were taking care of all the medical conditions, and orthopedic do their procedures. And then we manage post-op care, manage their pain, manage their DVT prophylaxis. When patient is stable, then patient can be discharged. So this is the interlinked. So this is how we can manage orthopedic cases as well. But of course, they are doing the orthopedic surgeons are doing the procedures, and we are, as a primary care hospitalist team, manage those joint replacement, bone fracture, aftercare, and arthritis, of course. And then outpatient care setting, we see the patient with backache, chronic backache, some shoulder pain, osteoarthritis, gouty arthritis, and fibromyalgias. All right. And also now the eye conditions, eye disorders, ophthalmology conditions, what we can do, like as I mentioned, for ENT, ENT stands for ear, nose, and throat. The otolaryngologists who do this procedure, whenever we need some complex cases, we refer to them, but we can manage otitis media, means inner ear infection. Otitis externa means external ear infection. Then rhinitis, sinusitis, tonsillitis, these we can manage as an internist. And ophthalmology cases like conjunctivitis, as I mentioned before, dry eyes, blepharitis, these are all the conditions as a internal medicine physician we can manage. All right, so pretty quick general conditions that we can manage, like fall, metabolic disorders, encephalopathies, arthritis, and again, in the office setting, we can manage backache, anxiety disorders, depressive disorders, fatigue, bipolar disorder, and OBGYN cases we can manage like cervicitis. We can do procedures like we can do pap smears in office settings. We can do testing for the STDs, both male and female. So these are outpatient care general cases we can manage as an internal medicine physician. All right. So this was an overview, pretty quick. You have a better idea what internal medicine physician can do. And of course, most importantly, prevention. Most of you have heard prevention is better than cure, right? So always we have to educate the patient as a physician, as a primary care physician in outpatient setting. We have to educate the patient, counsel the patient, because you have a good rapport build up with the patients. So when you have a rapport build up, they listen to you, they want to have, so you play a vital role in their health maintenance as well. All right. So again, pretty quick, as a hospital medicine, when if you want to prefer to go as in the hospital, we should have a bedside manners. I will go over pretty quick. So bedside manners, I will talk about briefly communication. What does that mean, communication? Active listening of the patient, have a compassion. Like you feel like whenever your loved ones is sick, what do we do, right? We have a real compassion for our loved ones to get better. We try to do everything to help them, right? So this is the same compassion and empathy we have to show for our patients as well. So I try to treat all my patients as my own loved ones, my own family members, right? So we have a different feelings when we for our loved ones. So please, whenever you're coming in this profession, bring that compassion with you for all the human beings, regardless of the color, race, religion. You are a physician for that patient. And then credibility, and of course have honest and open discussion with the patient, involve them in the care, give them all the options, because I always tell the patients, I'm your physician, but I'm giving you all the options. You are the boss of your body and mind. You tell me what do you want. But if sometimes they say, no, we don't want it, so I explain to them, I educate them, I counsel them, this is best for you. These are risks and benefits. So if they still, again, I leave them for them, but as a physician, I give them my honest opinion to them. And of course, most of the time they listen to us. And of course, we are trying to have for the best health maintenance. And of course, always try to sit at the eye contact level. Don't tower the patient. This is what I learned from my professor when I was doing residency, learning from Dr. Flannery. He was my internal medicine program director, and he was one of the best physicians. And now he's not with us anymore. And I always mention about him. He was one of the best physicians. I learned from him. That don't tower the patient, because patient lying down, I know sometimes we don't have a chair, so just try to lean forward a little bit down at their eye contact level. Don't tower the patient. And I always tell them, like, treat them like as the mom. You know how moms treat the kids whenever we are sick. When our kids are sick, we go to our kids, we put the hands on their forehead, talk to them, listen to them, and they have a feel that you're there for them to help them. Okay, all right, good. So let's move on. So just before starting the simulated case, I want to go over what we do, what I'm going to talk to that patient. So we have a simulated patient today with us. We'll have a briefly discuss one of the case. I know. So what I try to do, I start with the basics. And then, of course, we have international medical graduates who are already physicians, and they're taking their USML exams. So I go at the higher level as well, but I try to explain the terminologies that undergrads and high school students can understand as well, and have inspiration to learn and go in the medical field. It's very highly rewarding profession. So history taking skills. I will not go into detail, but I will just tell you what we do, how we go the diagnosis. So that when I will talk to the patient, you will have a better idea that what I'm doing. I'm obtaining the history from the patient. I'm asking the details. So I will go with make the diagnosis and think about the differential diagnosis and think about what the next step should I need to take to help the patient. So first of all, we ask the patient the chief complaint. Why patient is here? Why patient came to see the office, or why patient go to the hospital setting? So I'm going to talk about both inpatient and outpatient. So that's why I went over briefly about the inpatient, outpatient. So when I will use those terminologies, so you will understand what I'm talking about. So history taking, we ask the patient chief complaint, why patient is here? Why patient came to see you guys? Then history, we get more details about it. Then review of system, head to toe. We ask all the details, head to toe. And is there any other complaint? Then past medical history. Then we ask about the medication history. We ask about any allergies, the social history, about our family history, and the medication history. All right, next we go, then after history, what we do. So based on the history, we start thinking about a differential diagnosis. Because when you go in the medical school, you will, of course, learn basic anatomy, physiology, biochemistry. You have a basic base of all these anatomy, physiology, learning about the body, anatomy, physiology, then examination. So next skill for clinical, when MS3, MS4 learn more clinical skills, but I will just go pretty quick. What we do general examination from head to toe again, head, ENT exam, eye exam, neck, cardiovascular system exam, pulmonary exam, abdominal exam, genitourinary if needed. Sometimes we defer if not needed, neurological exam, then dermatological exam, and then psychiatric evaluation. So for all these, with the 3-4 steps we do: inspection, palpation, auscultation, and percussion. I will not go in detail. I'm just giving you terminology. So you will, at least you heard one time. Don't worry about it if you don't remember. It's just practice, practice, and practice. So just hear one time: inspection, palpation, auscultation, and percussion. And then sometime in future, I will go over in detail as well. And I know the IMGs who are with us today, they know what we are talking about. Okay, next, please. And then after examination, what we do the diagnostic workup. So this doesn't mean we have to do everything. We just do based on the specific symptoms, what patient came from, what patient need help with. So we do basic testing, we do blood tests, CBC called complete blood count, CMP called complete metabolic panel. We do the lipid panel, we do the A1C, we check for this test we do for the diabetes. We check the TSH, called thyroid stimulating hormone, and free T4 levels. This is for thyroid. So I'll talk more about it as well. Then we do the EKG. EKG is the electrical rhythm of the heart we check. Then we do the UA means urine analysis, we check. Then we do some imaging if we need it. Like we do the X-ray, we do the ultrasound, we do the CT scan, we do the MRI, so we do the PET scans, and we do the ERCP if needed. Okay, all right, next. So after history, examination, blood test, we do the assessment plan. We make what we're supposed to do now. So then we make diagnosis, we start some medication to help them, right? We make a treatment plan. And of course, in outpatient setting, we do lifestyle modification, we do counseling, and when we ask for the social history, we know about if the patient is smoking or not. We counsel about smoking cessation. And we talk about if patient is overweight, we talk about stress weight reduction, lifestyle modification, and then if patient has some anxiety disorder, we talk about the stress management. Besides giving the medications. All right, so let's start our simulated patient case today. And I have a disclosure over here that information is just for educational purposes, and please only for the students. And please do not use this information for treatment of any medical condition. This is not a substitute for medical advice. So you should not disregard your physician's professional medical service advice or delay seeking care because of something you have learned in the simulated patient case study that we will do today. Okay. And always remember to call your doctor or 911 in case of any emergency. All right. So let's move on. So we have a simulated case. Please go back. Simulated case, stay there. Okay, good. All right. So we have a patient. First of all, this is a patient I'm seeing in the outpatient setting in my office. Okay, so you have a better idea what's going on. So when patient comes in, patient check in the front desk. and then medical assistant room the patient. They take the vitals and they open up the chart for us. Just give you a brief idea what's going on. So now when we start talking to the patient is already in the patient examination room sitting there, and I'm going to start a conversation. All right, let's start now. Go back, please. Keep it there. Okay, thank you. All right. Hi, Mr. Good morning. How are you feeling today?
Hi, Dr. Cheema. I haven't really been feeling well.
Oh, I'm sorry to know that. Can you please explain a little bit more what happened, which symptoms you have?
Yeah, right. Yeah, I booked this kind of 24-hour type of appointment with you. I know usually I have my annual physical, but I've just been noticing this really fast heartbeat. And I'm just not sure, what's
I'm sorry to know that. All right. Thank you for sharing with me. Can you please tell me for how long you have it?
It started yesterday afternoon.
Okay. And what were you doing at that time when they started?
I was just just normally I was getting ready for classes, really, for one of my bio classes.
Okay. All right. Do you have any stress at home or in college?
I mean, I'm pre-med, so I do have tests all the time, but I'm used to it now, but nothing unusual.
Okay, okay, I hear you. Okay, do you have any other symptoms? I want to ask about one by one, like from head to toe. I'm going to ask you a few questions if you don't mind. So do you have any fever, chills in the last 24 hours?
No.
Do you feel any tiredness more than unusual?
No.
Okay, I'm going to just ask about any change in the vision, any?
No, not at all.
No, okay. Any pain in your ears?
No.
Any runny nose?
No.
Any sore throat?
No.
Okay, do you notice any swelling in somewhere in your neck area?
No, I don't.
Okay, any chest pain?
No, just a fast heartbeat. So it feels like it's coming out of my
fast
chest.
heartbeat, you mean like palpitation, you feel like your heart is beating fast. Is that right?
Yes, exactly.
Okay, good. Like it's called heart racing as well. You feel like your chest heart is racing and fast. It's called palpitations. Okay, good. Any cough?
No.
Any shortness of breath?
No.
Any nausea, vomiting?
No.
Any loose stool?
No.
Any constipation?
No.
Any abdominal pain? Okay.
No.
Any pain in your legs or any swelling in your legs?
No.
Okay. I just want to ask, any headache or dizziness?
Slight headaches, but I think it's just because I've just not been sleeping as much.
Okay. Okay. All right. And I just want to ask about any redness anywhere on the skin area?
No.
Okay. So as you mentioned about your sleep patterns, how do you sleep?
I mean, I'm trying, I know I have to sleep at least 8 hours a night, but it's really impossible. Like during the semester, it gets really crazy. And, sometimes I have to pull all-nighters for studying for exams. So it's really sporadic. I try to get some sleep in at the library, I guess. I sometimes fall asleep in class. It's just, I try my best.
I hear you. I hear you. Okay. How's your appetite?
It's good. It's good. I eat pretty healthily. I started a new diet too, actually. Just to reduce my carbohydrates. I've been trying to lose weight.
Okay. So you mentioned about the sleep pattern. So it's not unusual. It's just sometimes because the test you're waking up late, but self-care comes first, right? So I always talk about whenever that please try to make sure you're having enough sleep hours so you have keep up your health as well. Okay. All right. Yeah. So thank you for sharing with me. And now I will pause here. I will stop here with my simulated case and I will go back to all my students. So what do you think? I'm gonna, next slide, please. So this is what patient is telling us. So our patient is 23-year-old female. She came to the clinic because of the palpitations. But she mentioned to us that she has a heart beating fast. So we call it palpitations for plus 18 hours and last 24 hours. And it was started while she was getting ready for college. And so now when we check the vitals, the temperature is 98.6, blood pressure 102/67, pulse is 109 per minute, respiration is 24 per minute. And I did a review system with the patient. And she said no other than mild headache off and on and some sleeping patterns. So on examination, we will do exam as well. So let's do the exam first and we'll, so I'm gonna start the exam first. So what we do, So I'm not going to go head to toe exam here for our simulated patient. So for a simulated patient, I've patient mentioning palpitations. So my main focus, let's go over first differential diagnosis. What do you think based on the history, based on the vitals? Then I will talk about the examination, how, of course, exam is there. Patient has a regular heartbeat, but of course, has tachycardia. There's no murmurs heard. Lungs are clear to auscultation bilaterally, and ECG shows sinus tachycardia. And I will show you first, how do we auscultate? And you will listen the sound first. Can you please turn this on, the normal heartbeat, how it sounds like. Okay, all right. So this is the normal heartbeat. This is okay. This is the fast heartbeat. The normal heart sound. I'm going to show you. I'm going to turn this on for you. First of all, let's go back to first side. So I'm going to auscultate this patient. So what is auscultation? So as I mentioned, inspection, palpation, auscultation, and percussion. So I'm going to just talk briefly about auscultation. So this is a method used to listen the sounds of the body during a physio examination. So in my simulated case, in our simulated case for today, I'm going to listen the heartbeat. So how we do that? The stethoscope, you have seen with your primary exam, and you go see your doctor, they listen your heartbeat from different areas. So I'm going to talk very briefly about it. There are different areas we listen. Next, please. So there are 4 valves area that we listen. This is called aortic valve area. It's between the right second intercostal. First of all, I'm going to give you briefly about anatomy. This is the rib cage. They're different. This is the right side, the left side. This is the rib cage number 1, 2, 3, 4 till 12 here, 12 this side. And then when I said second intercostal space. So between first and second rib will be the first intercostal space, right? And then between second and third ribs, there will be the second intercostal space. So we listen the 4th heart valves area. This is called aortic valve, pulmonic valve, tricuspid valve, and bicuspid valve. So we call it APTB. These are areas we listen. This is an aortic area between the right second intercostal space. Then we listen the pulmonic area. Is in the left second to third intercostal space. Then we listen the tricuspid area. That is the left 4th to 5th intercostal space, either sometimes 4, sometimes 5, it depends. And then bicuspid valve area, we listen in the left 5th intercostal space. It's the mid clavicle. This is the clavicle. This is the left clavicle, this is the right clavicle. So mid clavicle means over here. This is the left mitral valve area. So aortic, pulmonic, tricuspid, mitral valve area. So we listen these 4 main areas. There are more details. I don't want to give you more detail at this time. I'm just letting you know that what do you mean by auscultation of the heart. Okay, next please. And then EKG, this is the normal sinus rhythm, how it looks like. This is the P wave, Q, RS, and this is a T wave. Again, this shows the atrial contraction, this shows the left ventricular contraction, then this is the repolarization or relaxation of the heart, but I will not go in detail again, but I just want to show you a picture in the EKG, that is the electrocardiogram. It shows the normal heartbeats. You can see the PQRS waves between these, and then sinus tachycardia. You can see, I told you this is the P wave, this is the QRS, and this is a T wave. So you can see the distance between. So these are the how we read the EKG. Briefly, pretty basic. These are small square boxes. So you can see 1, 2, 3, almost 4 boxes difference. Over here, you can see almost 1.5 box difference, right? So this shows us this is tachycardia. Tachycardia means heart rate is very fast. I will not go in detail. Sometime I will go in detail about how we read the EKG. Okay, now next, please. Yeah, so all right, so this is the normal heartbeat. We call it loop-dub. So basically, this is the opening and closing of the valves: aortic valve, a mitral valve. All 4 valves I showed you in the diagram in the previous picture. So now this is the normal heart sound, right? And now I'm going to turn on how it feels like when the heartbeat is fast. Can you please turn it on? See, can you see the difference now? Can you hear the difference? So this is what we are listening when we are putting the stethoscope on these areas. So this is, okay, here we go. All right, so now you see the difference, normal heartbeat or normal sinus rhythm, how we listen, how we auscultate. I'm going to use this terminology, so you'll be used to it, auscultation, right? So how we auscultate normal sinus rhythm, and then when there's sinus tachycardia, how we listen when we auscultate. Good. So next, please. All right, so I will stop here. So now you know the history. We did the exam, we listened the heartbeat, we did the exam as well. So what do you think, what's going on with the simulated case? What's the differential diagnosis? Again, I told you, I want participation. There's no wrong and right answer. Just think which area system you think, even you just don't know what's going on, just tell me which system you think we should focus, or which organ you think causing the trouble. But I will say, think out of the box. What do you think what's going on with our patient? Just write down in the chat box. If someone unmute yourself and give me the diagnosis, I'll be more than happy to listen from you directly. Or if you don't want, you can type in the chat box. It's completely up to you. Okay, CAD, anxiety from study stress. Okay, anxiety, stress, AFib. Okay, good. All right, good. So these are all reasonable answers. Very good. Yeah. So you're right. These are all the possibilities. I'm going to move on next, please. So when the patient gives us the history, right, if it can be atrial fibrillation, it can be paroxysmal, but I showed you the normal EKG. It was a sinus rhythm and sinus tachycardia. But AFib EKG, I didn't show you. That is different. So you will see the difference. But I'm giving you just the normal one and the basic one. So I don't want to make you overwhelmed with how AFib EKG looks like. So a differential diagnosis can be sinus tachycardia. It can be atrial fibrillation. It can be, so I told you, think out of the box, hyperthyroidism, right? So I'm going to ask the question to my patient, when she had the last blood workup done, right? So I will go over why I'm going to ask it. So hyperthyroidism, it can be pulmonary embolism. Pulmonary embolism means a clot in the pulmonary vessels. Then drug-induced arrhythmia. Patient told me the patient is not taking any medications. Then cardiac structure abnormalities can cause this. Sometimes electrolyte imbalance can cause it. Like patient, the reason I ask all the review system, if patient has nausea, vomiting, diarrhea, so patient is losing electrolytes, that can cause it. When patient has diarrhea, this means patient is losing electrolytes, patient is dehydrated, right? Dehydration can cause it. Then anxiety, patient mentioned about a little bit stress, but not more than usual. Then, of course, when we talk about social history, we ask about alcohol intake, we ask about caffeine intake, how much our patient is using, and then viral bacterial infection can cause tachycardia or palpitations. All right, next, please. So I'm going to snapshot all this case, and you will, again, I will need your help. So again, 23-year-old female evaluated in the outpatient setting, and the patient came with the palpitations for last 18 hours. She has no past medical history, and her only medication is the oral contraceptive pills. She describes as a rash to sulfur-containing drugs. So this means she has an allergy to medication, sulfur drugs. Sulfur drugs are antibiotic that we give for treat the infections. And then patient denies, when we ask the social history, patient denies any alcohol use, denies any drug use, denies any tobacco use. So on examination, patient is anxious appearing. Of course, she mentioned that she has some assignments going on. And then when we check the vital signs, everything looks good other than pulse, that is high. So normal pulse is around 70, that we take the number 72 per minute, but again, 72 to 82, I'd say it's okay. But more than 95 or around 100 is tachycardia. Pulse is concerning. So her cardiac rhythm is regular as we auscultated. Heart rate is elevated, but there's no murmurs. So the sinus, the auscultation, you heard the sound, it was a normal sinus rhythm and there was no murmurs in it. So sometime when I go in detail about the murmurs, so you will listen extra sound. So when we auscultated, we didn't hear the extra sound. It means there's no murmurs, and lungs were clear to auscultation. We didn't auscultate the lungs. I just showed you briefly about the auscultation of the heart only in this scenario. And if I showed the EKG, that shows a sinus tachycardia. So what do you think? So now we have a differential diagnosis, we all the diagnosis, we examine the patient. So what do you think is the next step in management that we should order to know, to narrow down, because I gave you a long list of differential diagnosis, right? So when we have a long list of differential diagnosis, we have to make it short. How we can do that? We do the workup, right? So what do you think is the next step? These all can be the options, but I'm asking you, what do you think is that we should check in this patient to narrow down our differential diagnosis? You can write on the chat box. Again, there's no wrong and right answer. We are here to learn, so please feel free Okay, someone said cardiac stress test. Okay, right? Yeah, we can do that. Okay, what else? Okay, so you're right. But again, I would say 23-year-old female, right? It's not less likely that patient, we should not go for cardiac stress test. But in this case, I want to let you think out of the box. We should not jump on right away the imaging, cardiac stress test. But we do. I talk about briefly about the testing, blood test. So always think about the blood test first, right? Blood work, right? So which blood work? So correct answer is, I'm going to show you, serum. Serum means is a part of the blood, thyroid stimulating hormone level. Okay. So always do non-invasive test first. Go for the blood test first. Okay. Like I told you, CBC, CMP, I talk about thyroid, TSH as well, right? So that's why, because we have to do, because it's, first of all, we need to do blood test first. Okay, baby, I told you, patient can be dehydrated, it can be electrolyte imbalance, right? But we don't have options over here, CBC, CMP. I went to the third step, thyroid stimulating hormone, but I will go in detail why I'm talking about it and how thyroid can do it when I will go briefly about anatomy and physiology of thyroid gland. That's the reason I asked, does patient have any swelling in the neck area, right? I was asking about it. So these all the questions I was asking the patient are all relevant. That's why we do the review system from head to toe. So correct answer is thyroid stimulating hormone level. Why? So before I will go over why, I'm going to go over again the anatomy and physiology of the thyroid gland. So everyone have a better idea. I know I'm going to start the basic again. So pretty quick. So thyroid gland is in the neck area. Hold on a second. Let me go over. Let me see, where is my anatomy and physiology? Okay, all right, good. So thyroid have two lobes, right and left lobes. And thyroid is basically conical in shape and have an apex, base, and three surfaces: lateral, medial, and posterolateral. So these are all medical terminologies I'm using. So please don't get overwhelmed. And there are two borders, anterior and posterior. Again, it's medical terminology you will learn in medical school. And there's an isthmus, this center area. So if you feel in your neck yourself, you will not, if you will swallow, you will see something moving. So this is the trachea. This is the larynx, and this is the left lobe, right lobe, and this is the isthmus, and this is the trachea. So here's, if we have enlarged, if we notice any swelling, so the two things, either thyroid gland or we have a lymph nodes. I will not go in detail. I'm just telling you, there's a thyroid gland anatomy, and the two borders, anterior, posterior borders, and superior, inferior. So histologically, next please. So I'm going to brief idea. Said in the medical school, you will learn about histology. Histology means how a thyroid gland looks like under the microscope. So basically, it's composed of epithelial cells. This is the picture over here of the histology that we see under. This is the gross anatomy of thyroid gland. This is the microscopic picture that we call histology. There are epithelial cells surrounding the colloid-containing pools called the follicles. And the epithelium of the normal gland is cuboidal epithelium. And there are the blood vessels that surround the follicular epithelial cells. And the colloid is within the follicular lumen, you can see over here. And where the thyroid hormone is synthesized. I will just go this briefly, once two-liner of histology. And now I'm going to go over the main hormones of the thyroid. So the main hormones of the thyroid that release from the thyroid glands are two: thyroxine, called T4, and triiodothyronine is T3. So collectively, we call it thyroid hormone. So what is the function of thyroid gland? It releases the thyroid hormone. And what thyroid hormone, what's the function? So basically, thyroid gland produces the thyroid hormones that regulate body's metabolism, metabolic rate. It helps in the growth and development. It stimulates the heart rate. It stimulates the heart contraction. It stimulates the synthesis of the proteins and carbohydrates. And so these are briefly, I'm talking about the thyroid functions. Okay. And then whenever there's an issue with the thyroid, it can be hypothyroidism. Hypothyroidism means when there is a less thyroid hormone producing, and hyperthyroidism when thyroid gland is producing too much thyroid hormones. So what happens when there is an abnormality? We feel tired, there's lack of energy. Sometimes we have sleep issues. Sometimes after getting sleep, we still feel tired. And sometimes there's a certain weight loss, sometimes weight gain. So these are related with hypothyroidism and hyperthyroidism. And sometimes weight gain, weight loss, we cannot explain by the changes in the diet or exercise. So then we check the thyroid, make sure there's no issue with the thyroid gland. And then we have mood swings, we have irritability, we have anxiety, we have depression. And then sometimes we have sleep disturbances with thyroid, abnormal thyroid hormones. We have insomnia, we have sometimes excessive sleepiness. So thyroid gland hormones basically, remember, regulates our body's metabolism and also helps the growth and development. It plays a role in controlling the heart rate. It helps in the digestive function as well. It helps with the brain development and the bone maintenance. So I will just give you briefly why we're talking about hormones and all these functions. And I just give brief idea about so you have something in your picture in mind where we have a thyroid gland, how it looks like, how it looks under a microscope. All right. Okay, next, please. All right, so this was all about, so in our patient had a hyperthyroidism. So when we check the thyroid levels, so patient had a hyperthyroidism, and this means thyroid gland is producing too much thyroid hormones. So as I mentioned, the function of the thyroid, it regulates our heart rate as heart contraction. So when there's too much hormones in our body, causes increased heart rate, the tachycardia. So we have to manage so this is the case of the hyperthyroidism. Hyper means too much thyroid hormones producing by the thyroid gland. So I will not go in the treatment at this point. You just need to understand that at this point we're learning the diagnosis, how we diagnose a patient. And then there's a treatment plan for hyperthyroidism. What we do, we need to know why patient has hyperthyroidism now, right? So first of all, go with the basic blood test. Then what we do, now we figure out thyroid TSH is high. It's a thyroid stimulating hormone. We check the TSH and free T4 levels. So TSH is high. TSH is low and free T4 is high. So this is called hyperthyroidism. And then there's a management. We do further workup for that. We do the ultrasound of the thyroid gland as well. And then we start managing, and we see any thyroid nodules are there. And we see any adenoma, the thyroid tumor can cause it. So there are different multiple conditions. I don't want this will be complex for you guys. I just want to let you know at this point, our simulated case was for hyperthyroidism. And just give you briefly about thyroid gland, histology, function, and how we can diagnose this patient and go with the basic workup. And I will not go in the management of the hyperthyroidism at this time, and I will move on to the next case studies. All right, so next we have, so this patient, this is a case study. This is a 55, any student can read this for me? Let's see if any volunteers we have here. You have to just read this case study for me, and then we'll talk about it. Anyone can volunteer?
A 55-year-old man with DM comes to the office for a follow-up post-ED visit for chest pain. He reports that he developed left-sided chest pressure with feelings of indigestion over the preceding 2 weeks that lasted 10 to 20 minutes in duration. He initially attributed the feeling of indigestion to indigestion and took over-the-counter antacids for some relief. On further questioning, he also admits to escalation of symptoms for 2 days prior to the ED visit. Shortness of breath on exertion, and diaparesis with onset of chest pressure. He hands you the ED documents that indicate he was observed in the cardiac observation unit for a full 24 hours before discharge. Serial ECG showed a transient 1.5 millimeter ST elevation in the anterior leads, but no Q waves. However, CK, MB, and troponin levels were negative. Discharge diagnosis was unstable angina, and he was advised to start aspirin once per day and to follow up with his primary medical doctor for further management. Patient reports that he has some indigestion and chest pressure that started this morning.
All right, good, very good. Thank you, I really appreciate. So there was a few terminology. So DM is a diabetes mellitus. It should be written full. It should not be DM. It's an error at our end. DM for the patient has a history of diabetes mellitus. Okay, good. And now I really appreciate you read all terminologies. This is how we learn, right? I know a few words are new for you. There's ST elevation. This is the EKG they're talking about. And then these are all the symptom patient came in, and this is where the patient went to the emergency department. So I want to give you both inpatient and outpatient. So patient went to the ED. She had this diagnosis of unstable angina is the one type of the coronary artery disease. So this means patient had the coronary artery disease. And then when patient was discharged from the hospital, they told the patient to come go to the office. So patient came to the office. I'm seeing the patient, or any one of you are a physician, you are seeing the patient. So patient's complaining the day patient presented, same complaint of indigestion and chest pressure. So what we're supposed to do first? First of all, I would like to ask the question, what do you think the most likely diagnosis? It's pretty straightforward. Okay, let's go over the blood vitals first. Blood pressure 150 over 80 millimeter mercury. Heart rate 72 per minute, normal. Lab studies we did, glucose was 140 milligram. A1C. A1C we do for the diabetes. That tells us how patient's blood glucose is running in last 3 months. So A1C is 7.2%. Normal is 6.2 to 6.5 we consider normal. Then we call it pre-diabetes, and this is 7.2%, but we say is well controlled given patient has already has history of diabetes. And then cholesterol. So total is 285. HDL stands for high density lipoprotein. You will read in your biochemistry classes undergrad level as well. LDL is low density lipoproteins. That is 221. It's very high. So question was, what is the next step of management? I took that part off because management we learned during MS3, MS4 and during our residency. So it will be too much overwhelming for you. So I bring this question back to what do you think is a diagnosis? What do you think? Type in or tell me, what do you think? What's the different diagnosis? Coronary artery disease, peptic ulcer disease, pulmonary embolism, or COPD, chronic obstructive pulmonary lung disease? What do you think? CAD, okay, good. What else? Anyone else? CAD, okay, good. All right, yes, very good, very good. So now you understand by reading the scenarios. So when you will take your USML exam and you will be in MS1, MS2, so this is how I'm giving you how it looks like. These are scenarios. It comes, and then at the end you have to answer what is the next diagnosis, what is the next management, what is the anatomy, what is the physiology, what's going on. So this is the scenarios comes in the case studies as well. So in this patient, you guys are right, CAD. So now my question is, patient went to the ED for CAD. So they're stable angina, unstable angina, myocardial infarction. These are all types of CAD. CAD means coronary artery disease. So I will go in detail as well. I will give you briefly about anatomy, physiology as well. But I want to ask you, patient came to see me in the office, or patient comes to see you in the office. What you will do with this patient? Of course, in the office setting, we are limited, right? Patient is complaining that he has chest pressure again this morning. So what do you think? What should we do? You can type in the chat box, or you can unmute yourself to be more interactive. I really want this session to be more interactive. I don't want, again, I told you there's no wrong and right answer. We all are learning. I know you guys are pre-med students, right? Most of you are preparing for the MCAT. Most of you have gone through such cases, but I have international graduates as well. But of course, if you don't know the answer, just give your best educational guess. This is how we learn, okay? All right, good. Let's see how many responses we get over here. I know some common CAD medications are like statin or, okay. So you want to give some medicines. Okay. You want to give aspirin, you want to give some cholesterol medicine. Okay. Is reasonable. Anyone else? Maybe some sort of testing he had in the ED. Okay, good. Yes. So the reason I brought this question here, patient already has CAD, right? And you say differential diagnosis CAD. So any patient comes to the office and telling you that he has chest pressure. So what do we do in the EKG in the office setting? We do the EKG right away. We have in office setting, most of the time we have the EKG, that we get EKG in the office. And if there's any abnormality, we have better idea what's going on. The EKG takes few minutes, so we can get it right away. Blood test takes time. But when there's something abnormal in the EKG, we have to send patient to the ED, emergency department. Why? Because patient just recently discharged, right? So patient can have recurrent symptoms, and maybe patient has another blockage that he need more acute intervention. Instead of wasting time, what I do, I get the EKG, abnormal findings, call 911, send the patient from office setting to the hospital. Don't let the patient go to the home. That's the thing I want to teach you over here. So how it works, we need to have a better idea about the office setting patient, how to manage, and then ED, when this is the time to send the patient to the hospital again, because patient is telling me patient still have a chest pressure again. So what I can do in the office, I'm very limited, right? I cannot do blood testing right away. As you mentioned over here, troponin levels. So the troponin levels is basically the test we do that tell us about patient has a heart attack. You know, you have heard the terminology heart attack. What does that mean? It means patient has chest pain. Patient, so what we do, we check the EKG in the ED. Patient go to the EKG in the ED emergency department. So what they do over there, they do the EKG right away. They check the stat troponin. Stat troponin means right away they order the troponin levels to make sure patient does not have an acute coronary syndrome. All right. So next please. All right. So patient has coronary artery disease, and I will go over and next our third case, and I will go briefly about anatomy and physiology again pretty quick. So this, anyone read this case for me? Any volunteers here?
A 27-year-old male comes to the ED complaining of substernal chest pressure radiating to his jaw and left arm, associated with shortness of breath and diaphoresis, without relief for the past 30 minutes. He has a past history of asthma, for which he uses a beta agonist inhaler infrequently, and denies any history of hypertension. He denies any family history of coronary artery disease. He admits to occasional cocaine and marijuana use and reports using both recently. The chest x-rays also comes back normal. The serum electrolytes are within normal limits, and cardiac enzymes are sent and are currently pending. An ECG shows an ST segment elevation of 2 millimeters in leads V2 to V4.
Okay, good, thank you. So now I want to ask about, so you have the scenario case study in front of us. So what is the most important, appropriate, what do you think? What's causing his symptoms? So, of course, we're talking about a CAD, we're talking about coronary artery disease. So now we all know there's something related to cardiovascular system going on, right? It can be CAD, it can be something related to heart. But what do you think? What's the cause of his symptoms? Is a coronary artery atherosclerosis? Means blockage of the coronary arteries. The coronary arteries cause the blood supply to the heart. And then cocaine-induced vasospasm. What does that mean? The coronary vessels get vasospasm after use of the cocaine. Third, collapsed lung, means pneumothorax. Then pleural effusion. Pleural effusion means the fluid buildup around the lungs. These are all the, so what do you think? What's the cause of his symptoms? It's pretty straightforward. Look up his history and tell me okay. B, okay, good. Okay, very good. Yes, so it's cocaine-induced vasospasm. So again, a 27-year young guy, he's giving us a social history. Patient came in, so it's very straightforward. We are not thinking of the coronary atherosclerosis. We're thinking on patient has, but it can be, patient can have coronary artery atherosclerosis. Means there's a plaque formation in the coronary arteries. All right, so next, please. All right, it's pretty good, a brief anatomy of the heart. This is the right atrium, right ventricle, left atrium. This is the pulmonary artery, left pulmonary artery. This is the aortic arch. And then superior vena cava. From over here, we have an inferior vena cava that both comes in the right atrium. Then blood flows from the right atrium to right ventricle to the AV valve. Then from the right ventricle goes to the lungs, to the pulmonary trunk, and from the lungs come back to the left ventricle. Sorry, so left atrium. From the left atrium to AV valve, go to the left ventricle, and from the left ventricle go to the aortic arch and go to the all part of the body. Next, please. So this again the cross-sectional view. We can see the tricuspid valve between the right atrium and right ventricle. So tricuspid valve, you can see 3 cusps here. 1, 2, 3. That's called tricuspid valve. And then you can see over here the mitral valve, which is also called the bicuspid valve because it has 2 cuspids here. And then aortic valve, I told you we listen 4 auscultation areas. Basically, there are aortic, pulmonic, tricuspid, and mitral valve. Next, please. So this is the blood supply of the heart. This is the right coronary artery. So when I was talking about the coronary artery atherosclerosis, means when there's a blockage. I will show you in the imaging how the blockage looks like. So there's a right coronary artery supplying this right side of the heart, then the left coronary artery, and there are a lot of branches. There's a left anterior descending artery branches, left circumflex artery, then marginal arteries. And I will not go in detail. I'll just give you a brief overview of the blood supply of the heart. This is all called the coronary vessels. Next, please. So this is the angiography. So when I send the patient to the ED, emergency department, so when they see that the abnormal EKG, there's ST elevation, and when they take the troponin level is elevated, so it looks like there's some blockage going on. So what we do? So we send the patient, we call the cardiology, and they take the patient right away to the or their cath lab, called catheterization lab. We do the procedure called angiography. So they put the dye and they use a blood vessel from the groin area, sometimes from the arm. And they go in, put the dye in. These are all the coronary vessels. So these are normal coronary arteries on the left side of the heart, as I showed you the blood supply in the prior slide. And then these are normal coronary arteries, the right side of the heart. This is the right coronary artery, this is the left coronary artery, and then the branch is left anterior descending artery. Next, please. So how we don't know that? So this is normal. You can see all the dyes all opened up. But over here, you can see it's narrowed down here, right? So this is the blockage here. So this coronary artery has a plaque in there. So it's blocked here. So that's why patient has a pain. Why? Because this blood supply has been cut off, right? Patient heart is, because heart is a muscle. It needs a blood, and heart pumps, and then we get blood all over our body. So when heart is not getting blood, how heart will pump, right? So that's patient has a chest pain because heart muscle is not getting the blood because of the blockage. So this angiography is a procedure we do, and then if there's blockage, cardiologists put a stent in there to open up. They put a stent over this area and open up so they can resume the blood flow of the coronary vessels to supply the heart muscle. Okay, so this again in this slide you can see the blockage here. That was in the imaging. This is the blocked coronary artery, and this is the heart muscle. This is affected by the lack of the blood supply, lack of oxygen. Again, this is a normal artery. You can see the blood vessels over here. There's a plaque formation. How? What's the risk factors? I'm going to go over pretty quick the risk factors. So risk factors of atherosclerosis. So first of all, the different constitutional, modifiable, and some other factors that can cause atherosclerosis. Genetics. Some people, like that's the reason we asked about a family history. Then with age our blood vessels get thickened, and then gender is another contributing factor. Then modifiable factors, addition factors, inflammation can cause this, and hyperhomocystinemia can cause this, metabolic syndrome can cause this, lipoprotein A, and these are all the additional factors. So what are the modifiable factors? Hypertension, it can cause atherosclerosis. Then hypolipidemia. If you remember from our patient has the LDL of in 200s. So it's very, very high. It's called formation of the plaque. And then diabetes mellitus. Smoking is another risk factor. Stress is another risk factor. So these are all the risk factors of atherosclerosis. All right, next, please. Okay, so now I will stop here for my cases, and pretty quick, I will go over self. Go back to the previous slide. Okay, oh no, there's no self-care slide. Okay, so can someone tell me what is self-care? What is well-being? So all my talk, I always talk take a few minutes to talk about the self-care. What is self-care? What do you think? When someone asks you what is self-care, what is self, what is well-being, what comes in your mind? Okay, something you do to benefit yourself, right? Taking care of yourself, yes, definitely, and prioritize is good, very good. So definitely, so self-care has 4 domains. Pretty quick, I'll talk about physical health or physical intelligence. It's related to our body. Mental health, mental intelligence is related to IQ. What we're doing right now, we are trying to work on our IQ, get more information, right? Emotional health, emotional intelligence is related to our heart, our passion, and then spiritual health and spiritual intelligence. So why do we need self-care? Can someone tell me why I'm talking about these 4 domains about self-care? Why? Why do we need self-care? Let's see. Why do we need self-care? Yes, and maintain our physical, mental health. Yes, yes, definitely. Yes, good, very good. So we need self-care. We need to be compassionate. I mentioned when you go to see the patient, be compassionate, right? So, but you have to be compassionate with yourself as well to avoid the burnout, to achieve your goals, right? So that's the reason, that's why all my sessions, you see, I always talk about it. Before I was talking in detail, where I'm just taking a snapshot. We have to avoid our burnout. You have to take care of yourself as well. As a physician, as your mentor, I'm concerned about your health as well, right? And in medicine, it's a long journey. It's the 4 years of undergrad and 4 years of medical school and 3 years of internal medicine residency. And if you go in the fellowship of gastroenterology, cardiology, then again 3 years. So it's a marathon, right? It's a long, and of course you need a passion for doing that as well. But I don't want you to burn out as well. So if you want to pursue that path, you have to take care of yourself as well. And lifestyle medicine is all about taking control of yourself, your well-being, improving your health. And the reason, if you're healthy, then you will be able to take care of others as well, right? If you're sick, if you're not able to go attend the classes, if you're not able to attend your assignments, you will lag behind, right? So it's very important to take care of your sleep hygiene, take care of your diet, make sure to do exercise every day. Just I'm focused on physical health. Therefore, I make an acronym for myself, SELF. S for sleep hygiene, E for exercise, L for learn how to manage stress, F for food. Try to add more vegetable foods in your diet, try to avoid junk food in your diet, and eat healthy, and try to do just 5-10 minutes exercise, and it will help you with your well-being and self-care. All right, I'll stop here, and next pretty quick, last slide, keys to success, your passion. As I mentioned in the beginning, your passion and profession should be the same. If you're passionate about whatever you want to do in your life, whatever your goals are, you're not even working a single day. I always give example, like we are watching movie, 3-hour movie, right? It just goes away like this. So we just started and it was done, right? Because we're so passionate about watching, we're so involved, we're out of time and space. This is how you have to be passionate about your goals, whatever you want to do in your life, and be comfortable with the new things. You have to leave the comfort zone. I always mention 3 C's. Credibility, leave the comfort zone, avoid any conflict of interest, and get over the resistance to change. You should have a growth mindset, be optimistic to make a change. And of course, peace, passion, profession, and persistence and grit. So I will stop here, and thank you everyone for joining for today's session. And we'll try to make, if any one of you want to be a simulated case in the next session, you're more than welcome to volunteer. And any case you want to discuss, you're welcome. This is my email. You can send me email as well. I don't check most frequently. It's better you send email to TeleShadowing team, and they can communicate with me as well. But any pressing issue, please feel free to contact me anytime. I'm always open to mentor. And if you're not able to hear from me, please send email to TeleShadowing team. We have a very good executive team just hired this month. They're very passionate about it. And always remember, your passion and profession should be the same. Then you're not working a single day. Okay, I'll stop here, and I will say best wishes in your career. And I hope one day you guys will be doing TeleShadowing session as a mentor. Okay, best of luck.
Thank you so much, Dr. Cheema, for this incredibly informative session. We really appreciate you taking the time to mentor us and teach us so much about the importance of self-care, well-being, the case studies. I know I had a lot of fun being your Miss Jane Doe. So the link to the quiz for the session is now live. You will need a 70% or higher to pass and receive certification. So the link to the quiz is being sent now, teleshadowing.com/certification. And now on to our next session dates. The dates will also be posted onto our social media outlets, so please be sure to follow us at TeleShadowing. Next week, we'll be actually having a specialty we haven't spotlighted before called Diagnostic Radiology and Nuclear Medicine. And August will actually be our rheumatology specialty spotlight month. So we'll be having doctors, all who are rheumatologists, kind of teach us the ropes of their specialty. All right, that concludes this week's shadowing. We hope to see you at upcoming sessions as well. And thank you for joining. Take care.